My name is Dr. Martin Dietrich. I'm a medical oncologist in Orlando, Florida. Immunocompromised state is a situation where a patient, for an underlying medical condition or secondary to a medical treatment, is not able to fend off infection as strongly as it normally could. So this is a situation that we encounter frequently in oncology, typically related to our treatment. There's some hematologic conditions that occur intrinsically with an immunocompromised state, but generally we would consider most cancer patients at an increased risk for infections. The complications of COVID-19 as it pertains to cancer are still subject to a lot of investigation. What we have learned is that patients are at an increased risk and have an overproportional representation in the victims of COVID-19. We don't quite understand why that is, and we haven't been able to fully work out a paradigm when patients should be withheld from treatment, when it would be advisable to delay or postpone treatment. But it does seem that there's a certain susceptibility that cancer and cancer treatment, at least in its active state, is conferring for patients in the context of a COVID-19 infection. For patients that are being treated with oral cancer therapies, I believe it's important to distinguish the kind of oral cancer therapy they're getting. If they're getting conventional chemotherapy, I believe the concern about immunocompromise and an increased risk of infection is certainly higher than it would be for other medications. There are certain anti-hormonal medications that patients are taking at home as pills that probably are not associated with an increased risk, at least not that we are aware of at this point. Obviously, we're learning as this crisis is moving forward. There are certain other targeted therapies that may have not a direct impact on the immune system, but they may have an overlapping appearance of side effects, where a COVID-19 infection may very much represent like a side effect of the medication, especially in the lungs. Autoimmune pneumonitis from COVID-19 may very well look like a pneumonitis related to a drug effect. This is a very difficult scenario. Those are difficult to distinguish. We see the treatments would be very different. We frequently use steroids for drug-induced pneumonitis, and it appears that in COVID-19, steroids have an adverse impact on immune function and thereby potentially make outcomes in COVID-19 infections worse. So it's a judgment call in the individual situation whether or not a patient can continue a therapy, whether it is advisable to hold a cancer therapy. And this has to be done both in a multidisciplinary setting of different experts as well as in a direct communication with the patient. As I said, there are a lot of unknowns that are currently still in the process of development, and I believe we need to be particularly cautious with our vulnerable cancer patient population. The timing of initiation of cancer therapy and COVID-19 infections is one of the highest levels of concern that we currently have in oncology. There are multiple approaches to this. There are some clinics that are now screening every patient ahead of treatment. This is what we are pursuing in our clinic. We are evaluating every patient for the presence of a COVID-19 infection. But what has become clear is that the vast majority of patients that are carrying a virus infection with the COVID-19 agent actually do not progress to develop symptoms. So we don't really know whether or not the initiation of cancer therapy is actually causing a detriment in these patients. It doesn't appear that the infection by itself is really the major clinical problem, but an overshooting immune reaction. And how that balances between initiation of therapy and the development of the infection is ongoing investigation. It is important to put this into the proper clinical context. If you have a highly symptomatic small cell lung cancer patient, obviously postponement of treatment is clinically not feasible. It has to be with the understanding in a very open dialogue with patients that the risk of an infection is there, and we still don't particularly have all the information about COVID-19. There are other scenarios where the intervention may not be as useful, it may not provide the same level of clinical benefit, and a postponement should be discussed. This is said in a setting where we have a lot of need for additional data to guide us in the proper setting. And for patients, obviously one where they have to be involved in clear and honest communication about the new challenges that the COVID-19 prevalence in the patient population does pose for us. Surveillance of cancer patients obviously has changed the most. Those are patients that have a lower level of acuity and are probably not as susceptible to the COVID-19 impact as some of the patients with active disease and active treatment. NCCN has given out a number of good recommendations with regards to surveillance. One of them is to basically spread out the number of scans that are being given. I think this should be done within reason, and also depending on the individual risk. I think a patient that has been out many years from a cancer probably wouldn't be hurt as much as a patient that has just been completing therapy. We currently don't have a forecast on when this COVID crisis is going to be more manageable, but I believe most of us think that by the summer it'll be feasible to actually restart proper screening. The avoidance of medical care facilities, both for the risk of infection as well as the cross-contamination, I believe is currently our highest priority. So my recommendation is to not go by the literal numbers. In oncology, we always love numbers of 3, 6, 12 months. I believe if we push this to from 6 to 8 months, I believe that there's not going to be a measurable impact on cancer patients by delaying these scans. I believe my concern right now is with the infectious risk of patients, and not to necessarily stick to the tightest schedule possible. So I would follow the NCCN recommendations to adjust this to the individual clinical risk scenario and to space them out whenever clinically possible and justifiable. Now, this is a change that has to be discussed with the patient. Obviously, they have to understand if a change is considered. But there are certain other factors that we also have to consider. There are some patients that are worried about COVID. There are many patients that are very worried about their cancer. And you have to put the psychosocial aspects of these test timings into the discussion as well. If a patient is particularly concerned, I believe it is reasonable to stick to the schedule. The idea is to spread out the visits, to allow for proper disinfection in between patients, and to minimize exposure to staff and providing proper protective equipment, both for the patient to prevent spread and also for the healthcare workers that are involved in obtaining these screening studies.